You probably noticed that I think Tuesday evening I went home and I found the first cardiac lecture from last semester, and I loaded it into your taker so that you can hear it. I think that it's probably cut off at about the same time that I cut off. So I think that maybe a few slides different. So it should. Yeah. And that's because I use the wireless mic. So this mic is better. I didn't realize, I think, how good it was because I think that Andrea asked a question in class, and you can hear the question in class all the way from the back of the room. It's Andrea, right? Yeah. So it's a good microphone. So I think that I will not use the wireless one anymore.
And the other ones were awesome. I listened to them all.
Good. All right. So any questions about last time? I think that sometimes I go too slow, sometimes I go too fast. So I think on Tuesday I didn't cover enough material. So here we are today with a lot to cover. But if we don't finish it all, we'll just stick it on to next Tuesday with the beginning of respiratory, because I think usually I have plenty of time after that first part of respiratory, because all that we'll do is go over ventilators, which will seem like Greek to you. So I'll spend a little bit of time on it. But also we'll re-review ABGs. I think that comes right after, well, you don't have the slides yet, do you? I think that comes right after ventilators and airways and things like that. So if you guys in the past have learned how to evaluate simple ABGs, we'll evaluate a bit more complex ABGs. And we'll get over the stress of, oh my gosh, is it metabolic acidosis? Well, if you can identify that, so what? What do we do about it? How do we fix it if possible? So anyhow, so we'll go over that, and I'll show you how to interpret ABGs even more than what you already know. So anyhow, so if we have cardiac left over, it will be put into it with that first respiratory lecture. All right? Sound like a plan? So we stopped last time in the middle of heart failure. Are there any questions about heart failure? Hopefully you guys are understanding the pathophysiology of heart failure.
Can I ask a question real quick?
Yep.
About the anticoagulants?
Yeah.
Okay.
It always confuses people.
Okay. You said 48 hours.
If the person has been in AFib, A-flutter for more than 48 hours, do not cardiovert them.
Okay.
They
It
should
doesn't
be
matter whether
anticoagulated.
you're giving them Coumadin, heparin.
You can't cardiovert them until they're anticoagulated, which takes how long?
4 weeks.
Like 3 to 4 weeks, yeah, maybe 2 weeks for some people, but an extended period of time.
Okay.
So
that has nothing to do with
so
heparin,
I don't know. I'm just going to make a
Coumadin,
question. A
or
patient
Lebanon.
presents to the ER in AFib, has been reporting heart palpitations and dizziness for 3 weeks. Which of these would not be an action? And it would be cardioversion, right?
Okay.
Because they've had symptoms for a long time. We don't know how long they've been in AFib. So we wouldn't, our first action would not to be to set them up for cardioversion. It would be to get some heparin going, or start some Coumadin, or do an EKG, whatever, you know. So it wouldn't be cardioversion. Does that make sense?
Yep.
Yeah, I think I'd say too many words to describe that sometimes, and it confuses people, but that's what it means. Here you go. Any other questions? Heart failure. It's important, okay? Heart failure is very important to understand. There are lots and lots and lots of patients with heart failure, and we need to know how to take care of it. So I think this is the slide that we ended on maybe last time. Like that. So let's talk about the diagnosis of heart failure. First, we'll talk about some labs. The labs that most accurately or specifically measure the degree of heart failure are BNP and ANP. And probably the best of those two is BNP. So when your patient has heart failure and they come into the ER and they're having an acute heart failure exacerbation, maybe they decided that they're going to, eat 7 bags of chips and drink 2 gallons of water. Well, that's going to put them in a heart failure exacerbation because of fluid volume overload. I'll tell you why later. But so they're going to measure their BNP. It's brain nitric peptide. That's what it stands for. I don't know how it got that name or whatever, but
it was found first in the pig's brain.
Oh, is that one? Okay. So, but this peptide, this enzyme or whatever it is released more when the patient has a higher degree of severe heart failure. So the more severe or the worse the heart failure, the higher the BNP. I think that your textbook will say that a BNP should be less than 100 or so, but nobody gets excited unless it's 1,000. But if you work in the ER and have been around any patients like this, you'll know BNP. It'll come back alert lab from the valley, so you're running to tell the ER physician it's 700, whatever. They don't really get excited until it's 1,000. But just to know that normal is usually less than 200 or 100. So good. Electrolytes. UA and LFT. So we talked about how the heart failure can cause organ edema, specifically liver, right? So what would you check? The liver function study. So that can tell you about the function of the liver. A lot of times when a patient is hypothyroid, low thyroid, their metabolism is low, it can exacerbate heart failure or be comorbid with it. So often they will go together. So that's why we might measure thyroid studies. And ABGs to measure oxygenation, the release of carbon dioxide, because the complication is what pulmonary edema that inhibits gas exchange, right? But out of these labs, which ones did I talk about the most? BNP, right? Imaging. So a chest X-ray, we do a chest X-ray anytime a patient comes in with a heart failure complaint. And why would we do a chest X-ray on these patients? We're looking at their heart, the heart size, somebody said. So a person with heart failure, especially if it's exacerbated, they're having a flare-up of heart failure. Maybe you can think of it that way, an exacerbation. What might you see on the chest? A big heart, right? A big floppy heart, right? And also, somebody said fluid on the lungs. So if the person is having pulmonary edema with it, especially if they have left-sided heart failure, that congestive heart failure causes pulmonary symptoms. So therefore, you would see some fluid maybe in the lungs. Right? As nurses, we're not evaluating X-rays, but over many years, you will see lots of X-rays, and you will begin to identify things. And we'll go. I think I've got a couple of X-ray pictures in here, and I'll show it to you. All right. So I said that most patients that are post MI or in just about every patient that has heart failure will be on an ACE inhibitor. Remember how ACE inhibitors work? Remember how to identify them? They all end in what? Krill, right? So these medications work how? Remember?
ACE inhibitors, vasoconstriction, decrease the blood pressure, and also increase the perfusion.
Right. So she's only the therapeutic effect, right? What's the mechanism of action? Inhibitates, that's a good guess, right?
Prevents vasoconstriction.
Prevents the conversion of angiotensin 1 into angiotensin 2, right? Well, what does that mean? Angiotensin 2 is a potent vasoconstrictor, right? So in essence, we're preventing vasoconstriction. It also helps with the perfusion of blood through the kidneys, and that's why it's a good choice in this heart failure, because it can help prevent renal failure, help the perfusion of the kidneys. Right? Some patients are allergic to ACEs. What is the major complication of an ACE inhibitor? Do you guys remember that? It's a side effect. You notice that I clear my throat a lot when I talk. I take an ACE, whatever. I can deal with it. But if I had angioedema, right, I would not continue to take it. That's a serious complication. Number one, right? And that is most likely to happen in what type of patient? Black patients. Black people. African Americans have a higher risk of having angioedema with ACE inhibitors. Come on, guys. This is review, right? If a person has an allergy to an ACE inhibitor, we can put them on an ARB, right? An angiotensin receptor blocker. So it doesn't prevent the conversion of angiotensin 1 to angiotensin 2. We still get angiotensin 2, but it prevents angiotensin 2 from working, from causing vasoconstriction. Prevents it from attaching to the receptor sites causing vasoconstriction. Right? So angiotensin, or an ACE inhibitor works sooner on the cascade, if you think of it that way, in the line of events than an ARB does. Very important medications to understand. I think you're pretty well versed on beta blockers, though, right? You know how those work. And you always think about beta blocker, and it blocks the beta receptor and causes decreased heart rate. Well, it kind of does do that, but then it kind of doesn't. So when you think about it, a beta blocker like Nibevolol or whatever will attach to beta receptors, but and block them so that what can't attach to them. See, that's what you didn't know, right? So what is it blocking? What are beta blockers blocking? Nobody knows, right? Norepinephrine. Have you heard of norepinephrine? Right. Epinephrine, adrenaline. It's blocking those sympathetic or sympathetic nervous system from working. That's what's happening. So now you see what is actually happening. The medication itself doesn't actually cause those things. It's blocking the receptors so those things don't happen. Because when you are in times of stress, your adrenal glands release epinephrine, things like that, and do what? Restriction, heart rate up. So beta blockers prevents that from happening, right? That's why you might take metoprolol to decrease stress or anxiety. You inhibit the sympathetic nervous system from causing blood pressure increases, heart rate increases. So there you go. Beta blockers. What are beta blockers? What do you think about when you think about the respiratory system when a person takes a beta blocker? So what disease that is related to the respiratory system would you be careful? Asthma. Good. Asthma, COPD. Yeah. Asthma is not COPD, but, and why is asthma not COPD? Because it's reversible. Right? Diuretics, which you're familiar with, right? Lasix is a big choice here. Lasix is what type of medication? It's a diuretic, but it's a loop diuretic, so it acts in the loop of inulin, right? But what's specific about Lasix? It's potassium wasting, right? So Lasix is potassium wasting. Which one is potassium sparing? Right, Aldactone is potassium sparing. So often your patient will be on both of those to counteract that side effect, right? Usually things like hydrochlorothiazide is not enough for this patient. That's a mild diuretic. All right, vasodilators. Like, what is a vasodilator? Think of an example. Hydralazine, remember that one? This one has low compliance. Why? Do you remember? Because it's dosed 3 times a day. Who wants to take medicine? I don't want to take medicine twice a day. I want to take it once a day. So you have to take something 3 times a day. But this can help lower blood pressure, lower preload, and help that left side of the heart, right side of the heart with preload, right? And digitalis, so digoxin, right? I think last semester in PEDS, you guys talked about digoxin, so you need to bring back all those memories about that, plus some more. So remember all the signs of digoxin toxicity, vision changes, right? Low heart rate, what else? EKG changes, right? Okay? So, and remember how it works. So what's the problem in heart failure? The heart is not an effective pump. So what is digoxin going to do to the heart? It's going to make it squeeze harder, right? It's going to slow it down so it can get some preload and make it squeeze harder to hopefully get some more what? Cardiac output, right? So why would we not use calcium channel blockers in heart failure. Sometimes they might, but generally it's not our first line for an antihypertensive. You think why? It slows the conduction, but so does digoxin. Wow. You're on the right track. So, what's the problem in heart failure? Decreased contractility, right? And how do calcium channel blockers work? Decrease contractility. Right? Does that make sense? Well, it would not be the first choice. It would probably exacerbate the problem. So, beta blockers are controversial in the use of heart failure, but most will use beta blockers with heart failure because they also cause decreased contractility. But they're more effective than harmful. But calcium channel blockers not first because and remember some of the side effects of calcium channel blockers that we think of. It's the side effects of heart failure. Peripheral edema. All right. We talked a good bit about it, but you know a lot about these medications, and the way that you'll study them is how. You will get out your drug sheets from your clinical, and you will say, okay, this is my beta blocker one, this is how they work, this is the therapeutic action. You don't have to memorize the normal dose, but you'll, all of your side effects, the most important side effects, the most common side effects, and the adverse complications, contraindications, and medications. Right? That's how I would suggest studying these medications. You're not going to learn bevolol, metoprolol, and labetalol. Just remember beta blockers, and then be able to identify them. All right? Why would the person in heart failure have to be on a sodium restriction? The more sodium we take in, the more fluid we're retaining. When a person is in heart failure, when you have extra fluid on board, it's going to decrease, even exacerbate the problem because we have more volume. It's going to become overloaded, and it can't be ejected and moved around all that volume. So this person will have even more backing up, more pulmonary symptoms, more edema. Okay. So sodium restriction. This person is going to have a 1, maybe 2 gram limit. But what is a normal sodium? We always talk about restrictions of sodium. What's a normal sodium for us? No more than 2.5 grams a day. So, and I assure you, probably half of you in here have gotten way more than that already today. But a normal person with good renal function and no heart problems process it off pretty well. But so just realize that the normal recommended daily intake is just higher than the restriction that we often give. So normally they'll prescribe a 1 gram. It's really hard to stick to. Exercise, but remember the person that is in heart failure, you're not going to tell them, okay, you need to get out and start running every day. That person will fall out dead in the middle of the road. You're going to tell them that you need to begin walking, moving around a little bit more, exercise within their limits, okay? And tell them slowly we can build your stamina and push the limits. But initially, they should start out only with what they can do, but doing something. I talked about how a valve can cause or can be damaged in an MI, and especially that mitral valve on the left side. If it's damaged and is regurgitating, the blood can be is not going out into the aorta properly. It could be being pushed back up into the left atrium because that mitral valve is not closing. Okay, that's like regurgitation. You could have, because of mitral valve stenosis, which we'll talk about, the blood's not getting from the top to the bottom correctly, so it's backing up, right, causing signs of heart failure. So a valve can be replaced if necessary. And eventually, especially if a person has a really, really bad ejection fraction, they can be put on the heart transplant list and get them a new heart. I think you're aware why impaired gas exchange. We've said it a few times, right? Decreased cardiac output because it's not squeezing, right? Fluid volume excess. This person if they have this, it's a big problem. And we know how to assess for and treat that, right? Be sure that you can. Activity intolerance. Why? Because we're not getting good cardiac output, number one, and also there's something going on in the lungs. We're not getting good oxygen. Yep. All right. Knowledge deficit usually related to the medication regimen. Electrolyte imbalances may be related to medications as well. All right, and disturbed sleep pattern. What's going on here? One of the things that should really alert us when a patient comes in and is having heart failure symptoms or something, we'll ask them, tell me how you sleep. And they're probably going to say, sleep in the chair every night. They have what? Orthopnea, right? You remember that term from foundations? All right, so orthopnea, that's the inability to sleep while laying flat, or the inability to breathe well while laying flat, and it inhibits sleep. So remember that. And it's because of the flow of blood through the pulmonary vasculature, and if they're short of breath, and of course you breathe better while sitting up anyway, especially if there's a problem. All right? Remember we talked about how blood pressure is a big risk factor also for heart failure. So, of course, that should be managed very closely. Heart sounds, what might you hear? Like with murmurs or whatever in S3, right? And possibly you'll hear murmurs if they have that mitral valve problem. Yes, ma'am?
Going back to the disturbed sleep pattern,
Yep.
I read where at nighttime the pitting or dependent edema resolves. I mean, is that some assessment you should know that edema may resolve whenever they're
Laying flat.
supine and
Yeah.
then get worse?
Well, probably, I would think what would happen is that it would redistribute, because if it's dependent, dependent edema is you've been on your feet all day and now your feet are full. That's dependent edema. But then they're laying down and the fluid can redistribute, so that might cause the
So
problem.
it doesn't mean like the ascites or all that's going to disappear. It's just mainly low.
All that edema is not going to resolve itself overnight. Yeah, the dependent, you're right, the dependent edema might resolve and redistribute itself. Yeah, but the fluid's not going anywhere. They're still hanging on to it. So, yeah, good. Heart sounds we talked about. S3, where do you hear in S3? Sorry. So you're listening to the normal heart, loved up, right? S1, S2. Where would you hear S3? Immediately after S2. Where do you hear S4? Immediately before S1. There's a pause in there, right? So just remember that. I think that comes up on a test somewhere. Maybe it's lung sounds if the person has pulmonary edema. We'll talk about pulmonary edema a little bit more, but we'll hear crackles. When you hear crackles, that tells you that there's fluid in a small alveoli, right? Cardiac rhythm, renal function, because what? Urinary output is a good indicator of cardiac output. That's the big problem here. So the patient, we want them to have renal output, renal function, because we want them to be able to process off extra fluid. If they can't, they're going to have a heart failure exacerbation. A lot of times you'll have patients with chronic renal disease and heart failure. Terrible combination. They probably got renal failure because of chronic hypertension and because they had heart failure. So, anyhow. Activity intolerance we talked about, edema we talked about, and the person, daily weights are a very good indicator of fluid volume status, outpatient especially. So tell your patients to weigh themselves daily at the same time every day, usually in the morning after the first void. So get up, go pee, weigh yourself. So and keep track of that. And remember how much fluid weighs. You remember?
2 liters, that's 0.4 pounds.
Is that what your book says?
I've been on a diet for 30 years.
Okay. All right. I think about a kilogram weighing about 2 pounds. A liter weighing a kilogram, which is about 2 pounds. A liter is about a kilogram. Is that about right? You remember it a different way. A liter is about a kilogram. Medication management is a big deal. And we can also give patients sympathomimetics, which we'll talk about a little more later. These are inotropic medications that cause increased contractility. And the one that you're going to see most frequently used in heart failure is dobutamine. So this medication is given intravenously, usually in a high acuity setting, either in a PCU, an ICU step down, or an ICU. So dopamine can be used too, but usually dobutamine is going to be the sympathomimetic of choice for heart failure. Right? I'll talk more about those. Pulmonary edema we've talked about, but remember this is fluid mainly in the alveoli. This is a medical emergency. This happens, and heart failure, #1 risk factor, right? You probably already really understand all this patho here, but because we have some backup of fluid, the left ventricle's crappy, fluid leaks out into the alveoli we talked about, and therefore gas exchange is impaired and hypoxia happens. Hypoxia and hypercarbia, right? Hypercapnia, high CO2. So this patient is unable to exchange gases because there is fluid in their alveoli. They're drowning. So of course you're going to have shortness of breath, difficulty breathing. And a classic symptom of this is pink frothy sputum. So the patient is coughing up pink, bubbly, frothy looking sputum. Have you ever seen it? Anybody? I've seen it. So this patient is really sick. Lots of signs of hypoxia, right? Cyanosis, all right? Remember that cyanosis is a late sign of hypoxia. If your first assessment of your patient being hypoxic is cyanosis, you are not a good assessor, right? So what are some early signs of hypoxia? Cognitive changes. Yeah. They're maybe get a little confused, get a little anxious initially. So then you start thinking, what's going on with this patient? So maybe they're just getting confused and it's, getting dark outside and maybe they have, sundowner syndrome. But you want to make sure, especially if they have a heart problem, they're not hypoxic. All right? So monitor your patients closely. So mental status changes are a number one sign of hypoxia. This x-ray here, just remember on an x-ray, or just FYI, on an x-ray, air is what color? Black. Okay? Everything else is pretty much white or gray. So here you have a chest x-ray of a patient who has pulmonary edema and congestive heart failure. So the lungs here should be, in a normal person, should be nice and black, full of air, right? Air is black on an x-ray. Everything else is white or gray. So you see the bones are white, picking up the calcium or whatever. So, but you also see all these infiltrations in here, all that's fluid filled in that lung. So that should be nice and black. You can also see the heart, and you can see that the heart comes way out here. That covers almost the whole width of the chest cavity. That's not good. A normal heart would be about this big. Okay? That's a big floppy heart. You see it? Not good. All right? Talk about the ABG, low oxygen. And another thing that maybe you have looked up is a pulmonary artery wedge pressure or pulmonary artery capillary pressure. And this is the measurement of the pressure in the pulmonary artery when it is occluded. And we can occlude the pulmonary artery with a very advanced catheter. And as that is increased, that just tells us that there's increased pressure in the pulmonary vasculature, which pulmonary edema is caused from it, right? Of course, cardiac output is going to be decreased. If this person has pulmonary edema, they must have oxygen, and often they require mechanical ventilation and intubation. We need to get the extra fluid off of this patient, and how you will be doing this is administering Lasix. Okay. To decrease afterload, we can give a potent vasodilator called nipride. This medication is extremely potent, and very small changes can cause big changes in our patients. So you have to very, very closely monitor their blood pressure while they're on nipride, because it is a potent vasodilator. But we give it to decrease afterload, to decrease the amount of work the left ventricle has to do. Because remember, afterload is the pressure that the left ventricle meets when it ejects blood. So the lower that afterload is, the easier it is for the left ventricle to get it out into the body. We do want some afterload to maintain a blood pressure, but this person's probably going to have elevated afterload. And again, we can give medications to increase the contractility of the heart. Likely, the patient will get all of this. Right? Impaired gas exchange, right? Remember the difference between impaired gas exchange and ineffective airway clearance. Sometimes the line gets very skewed and gray. But I'll think of it this way. If there's an ineffective or an impaired gas exchange, where is the problem? In the alveoli, right? That's where gas exchange happens. If there's an ineffective airway clearance problem, where's the problem? It's in the larger airways, right? So think of it that way. So if the air can't get to the alveoli, they have an ineffective airway clearance problem. If there's something in the alveoli preventing the exchange of gas, there's an impaired gas exchange, right? Of course, decreased cardiac output is in play here. And this person is going to have mental status changes, fear, anxiety, because why? They're hypoxic, right? You're not going to have a person who is calm who is hypoxic, right? Initially, eventually they just go out on them, but, code. But realize that these mental status changes, fear, anxiety, even just mild confusion in the beginning can signal hypoxia. And knowledge deficit usually related to the disease process or the medication management related what caused this problem like heart failure. Right? All right, so let me talk about some things that are a little bit boring real quick. I think that this is not exciting, but we'll get through it. Infective endocarditis, what does that sound like? Infection of the endocardium, right? And it is usually bacterial, and it's usually caused by Staph aureus. It's fairly uncommon. A big risk factor for this is IV drug use. Okay? Or problems with the valves. People that have any valve problems, like mitral valve problems or whatever, often before having dental work, they will go to their primary care person and they will give them some amoxicillin before they go to the dentist to help prevent this. This practice is becoming outdated. They're starting to learn that it really doesn't matter. They're doing lots more research, and there's really not a lot more benefit in the group that is given amoxicillin as opposed to the group that is not given amoxicillin. So this is becoming an outdated practice. Just keep that in mind. Okay? You'll still see it happen though. Urosepsis can cause infective endocarditis. IV CVC, central venous catheter, central line. Think about where a central line goes. Real close to the heart, right? Sometimes they're in the heart. So, of course, putting a foreign object near or into the heart, we're going to increase the risk of infection. But not just is it just that the heart is infected, but the problem really lies with the valves. So, for somehow bacteria gets into the bloodstream, and those bacteria attach to the heart valves, and it begins to grow in the heart valves. Those valves get damaged because there's vegetations, they call them, on the valves, and they don't work right. So therefore, you can end up with the misflow of blood, causing maybe signs of heart failure and things like that. Also, those vegetations, the growth of bacteria can break off and it can embolize and cause problems like strokes. Right? Strokes or pulmonary embolism. Yep. This is an infection problem, so they're going to have infection-type symptoms. Okay. Eventually, as it progresses, they will begin to have heart symptoms. One of the main things you need to take from learning about infective endocarditis is how to do blood cultures. So I want you to know how to do this. In your book, I think, or maybe in your skills book from Foundations, it tells you. But I'm going to talk about it, what's most important. So blood cultures, what are blood cultures? They're drawn to test for bacteria in the blood. All right. Number one, remember that they're very expensive. It costs $1,000 to $2,000 to run a set of blood cultures. Just keep that in mind, right? So if a physician accidentally double orders it, maybe the ER ordered it and then the ICU doctor ordered it too, you need to make sure that it hasn't been done yet. Because you say, hey doc, this has already been ordered, and the nurse in the ER says, oh, okay, we'll cancel it. Don't just blindly draw this, and then there's $2,000 more wasted healthcare dollars. All right, this is really expensive. Anyhow, so the blood cultures we draw to test for bacteria in the blood, so we should maintain asepsis when we're doing this. And how we do this is by cleaning the skin where we're going to draw the blood from with chlorhexidine gluconate. Right? Alcohol, if that's all you got, but alcohol is not the best antiseptic. Chlorhexidine is. Right? Usually you draw two sets, and they're drawn from two separate places. If your patient has a central line, you're going to draw one set from the central line. And the other set will be a peripheral stick, which you will do. Right? Sometimes the phlebotomists do them, but I prefer to do them myself. But whatever. So one will be drawn from the central line. And I've talked with my clinical group about this. Anytime that you access the central line, for how long do you have to scrub the hub? 30 seconds. Okay? You must stand there for an entire 30 seconds scrubbing that entry port. Okay? I don't care where you are. So next time you go to clinical and you have to do something with the central line, you scrub it for how long? 30 seconds. Watch your clock, watch whatever. And then, you probably know this, but anytime you apply something as an antiseptic, when do you know that it has been effective? After it dries. So let it dry for 30 seconds too. Okay? So you have to do this, especially when drawing blood cultures. You should do this at any time to help prevent the patient from getting sepsis. 30 seconds, right, Wendy? All right. So you draw the blood cultures from 2 different sites. Make sure that you use strict asepsis. Okay? That's really important. Another thing that is important is if you have new orders, maybe you have orders for blood cultures and you have orders for antibiotics. Write it all at the same time. You're going to get prophylactic antibiotics, or empiric, they call them. We don't know exactly what's causing it, but we're going to take a good shot at it. So what would you do first? The blood cultures. You draw the blood cultures first. Why? Because you might have a false negative. You give the antibiotic, you kill the bacteria, and then, we don't know what it was. So that's something that will make you feel really stupid if you do it. All right, so don't do it. We talked about an echo, and an echo can help us visualize the valves directly, and we can see what's going on there. CBC, right, elevated white blood cells, elevated granulocytes. ESR tells us about what? Inflammation. There's infection here, right? So there's going to be some inflammation. And the X-ray as well. This person is going to need long-term antibiotics. Use antibiotics we take for what? 7-10 days, right? 2 to 8 weeks, this patient will need some sort of antibiotic. And here are some things that they might use. Remember that it's not our nursing responsibility to prescribe and choose what medication to give. So this is just, FYI, this is probably what's going to be good. All right? And because if there's valvular problems, the patient can have surgery to fix those valves. Because there's infection, right? Fever, decreased cardiac output. Remember, it's the theme of this whole cardiac unit. Why ineffective tissue perfusion? Well, it's related to decreased cardiac output, right? I should really add that into all of them. Ineffective health maintenance. Drug use, whatever. Pericarditis is similar to infective endocarditis, but pericarditis is inflammation of what? The pericardium, right? So remember, talking about the different layers of the heart and how you need the endocardium on the inside, and the pericardium. Peri means around, so this is around the heart. Okay. So this is kind of like a membrane that surrounds the heart. Usually this is viral, and usually younger men have this problem. So the patho is a little bit different. We have inflammation in the pericardial space, not the endocardial space. So the problem is going to be more on the outside of the heart. So the inflammatory process causes the ability of the fluid to shift from the capillaries into the third space, and that space here is the pericardium. And the inflammatory process continues, and the patient will develop scar tissue from this plasma and fibrinogen that is in there. White blood cells, of course, also play a role in all this in the development of scar tissue. And when the pericardium is meant to be very flexible and move as the heart pumps, right? But it gets stiff and fibrous, so it can prevent the heart from moving like it's supposed to. And that's how it would cause decreased cardiac output. It can't expand like it should. So this person will have chest pain, which is exacerbated by deep breathing and coughing. Okay? Because you're pushing against that stiff pericardium as you're taking a deep Remember with an MI, you're probably not going to have increased pain with the deep breath. But with pericarditis, they will. All right? A pericardial friction rub, because the heart is rubbing against the pericardium as it is pumping. All right? Let's see. What else? We can have elevated cardiac enzymes because there can be damage to the heart muscle because it can't move properly. What else? Pulmonary artery pressure tells us about the pressure in the pulmonary artery. So as it's higher, we have an increased risk of pulmonary edema and things like that. CVP, remember, tells us about what? Well, it stands for central venous pressure, but what does it tell us about? It tells us about the pressure in the right atrium, but fluid volume status. So the higher the CVP, the more volume we have. Yep, usually. Unless we have a bad pump, and then it can be a false positive, a false elevation. See, I never say always. But in general, that's the definition of it. Chest x-ray to look at the pericardium. All right, so we can give medications that decrease inflammation, right? NSAIDs, aspirin. Remember that NSAIDs are things like aspirin, ibuprofen, naproxen. Tylenol is not an NSAID, right? And, of course, steroids decrease inflammation. They can pull out pericardiocentesis, is where they pull fluid off of that pericardium to decrease the problem here. And also they can remove the pericardium. Remember, the pericardium is kind of like a membrane that surrounds it. So if it's stenosed and stiff and it's not going to fix itself with the treatment, then take it out. Right. So the constrictive pericarditis is where the heart is enabled to pump. Same with cardiac tamponade. And pericardial effusion is lots of fluid in the pericardium, which is just going to exacerbate the problem. So especially if there's a pericardial effusion, that's when they would do a pericardiocentesis, right? Does that make sense? The centesis, anything that says centesis, pulling fluid off of something. What do they call it when they pull the ascites off? Amniocentesis, right? Not amniocentesis. It's similar. They pull fluid off of the ascites. Paracentesis. From the peritoneal cavity. That's right, yeah. Not amniocentesis. But that is pulling fluid off, right? Yeah. We're going to fix your heart and give you an amniocentesis. Yeah. I don't know. Infective breathing pattern, right? Because it causes pain to breathe. So therefore, the patient may have a change in the breathing pattern. Of course, decreased cardiac output and activity intolerance, right? And you know what? More boring stuff. Rheumatic heart disease. And you probably learned a little bit about this in peds, right? Because what causes this? Stress, right? And kids get stressed. Adults do too. So this is caused by a bacteria. It's caused by strep. And it's group A beta hemolytic strep. That means that this strep causes what? Hemolysis. You can have... So the patient basically will go from a strep infection like strep throat, streptococcal pharyngitis is a nice word for it. Then it can progress to rheumatic fever. So the patient has a fever and often will have what kind of rash? What do they call it? Salmonella rash, right? That can progress to rheumatic heart disease. And what's happening here is that there is an inflammatory process that happens in the connective tissues of the heart. And anytime that you have, again, inflammation, you have scar tissue to develop. They call these things Ashkoff bodies that form on the valves of the heart. So this is a valve problem again. So infective endocarditis, rheumatic heart disease, both are valve problems. So both bacterial, right? Caused by different things, though. A little bit different, but essentially kind of the same because you have malformations of the valves because of vegetations or growths on the valves caused by bacteria. Because what caused infective endocarditis? That is a strep. So again, signs of infection, right? But because it's a strep, group A beta hemolytic strep, we might have this scarlatina rash. May have all these terrible heart sounds, S3, S4, and a murmur too, because you have changes in the valves. HF, heart failure, right? Because of valve changes. So we're going to measure those labs that tell us about infection and inflammation. Throat culture will tell us about infection of strep in the throat. And all those things. Let's see. The patient will need antibiotics. Penicillin is the first line treatment for strep. Okay, so a lot of people have gotten this notion that penicillins are just not good anymore. There certainly are. They are first line for lots of things. Okay, and again, so with infective endocarditis and rheumatic heart disease, that goes into the issue of the dental work and prophylactic amoxicillin before. But again, this is becoming an outdated procedure. Chest pain, activity intolerance. All right, that's all I'm going to say about that. I don't have time to talk about cardiomyopathies. There's not a whole lot to know about them. But in your book, on this page, is a little chart. And I think there's 4 types in your chart, but know the difference between dilated, hypertrophic, and restrictive cardiomyopathy. I would say the most important thing to know here, I said no difference in blah, 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 but it's to know the difference in patho and manifestations. That's the most important. In general, cardiomyopathies will have signs of heart failure. Okay? So the person with cardiomyopathy is going to have signs of heart failure. Generally. We're getting there. Vascular disorders. I hate saying these words, so I'm just going to say these. Peripheral artery disease. All right. So peripheral artery disease is the narrowing of the lower aorta, and that's caused by arteriosclerosis, and it's causing decreased perfusion and blood flow to the lower extremities. Is that it? Something like that? Yeah. So we talked about arteriosclerosis, so that's caused by usually what? Messed up cholesterol, right? Hyperlipidemia, dyslipidemia, whatever you want to call it. Genetics play a role in that. All right? So the treatment of this should focus on treatment of the underlying cause, so management of lipids, management of diabetes, management of blood pressure, and lifestyle things like that, increasing exercise. So we want to prevent it, but also treat the underlying cause. Smoking is a big risk factor for any type of peripheral perfusion problem. So make sure that these patients are not smoking, and if they are, we need to teach them to not do so. I always call this Berger's disease. I don't know if that's how you pronounce it or not, but that's what I say. And I remember, and I think of that because I don't know, it's silly. I think of weird things, I remember things, but you think about a hamburger, and you think about men eating hamburgers. Well, it's more common in men breeding one, all right? So Berger's disease. This is not caused by arteriosclerosis, okay? This is a vaso-occlusive phenomenon. So this is caused from vaso-occlusion, vasoconstriction of the peripheral, of the hands and the feet.
Is that sort of like Raynaud's disease?
It's similar. Yeah. So it's very painful, and that's because the tissue is ischemic. The tissue can become so ischemic, the tissue can begin to die, and the patient can develop gangrene. And I don't know if you know what gangrene is. Gangrene is usually just the infection. It's just a culmination of a whole bunch of different types of bacteria causing an infection. It's gross. And have you seen it? Yes. Yeah. And it causes lots of tissue destruction. It's terrible. So anyhow, all right. So the number one risk factor here is smoking, and you would want to teach your patient to not smoke And also you would teach your patient to, stay out of the really cold weather too, because cold weather can cause, what it does cause, vasoconstriction, so it can exacerbate this problem. So keep their hands in their pockets, lots of socks, lots of gloves. The hand warmers, if anybody has ever been hunting, I think they make those packs that you put in your pockets. They can use those, right? So Raynaud's disease is similar to Berger's disease. I think about Raynaud's disease kind of, it affects women. Berger's is men. Raynaud's is usually women. Raynaud's is usually attached to some sort of autoimmune disorder too. But the problem here is that there is a problem with the mediation of vasoconstriction and dilation. So you have alterations in nitric oxide, not nitrous oxide, it's nitric oxide. And nitric oxide plays a role in vasoconstriction and vasodilation, as does vasopressin and angiotensin. We talked about angiotensin, right? So usually a person with Raynaud's will have manifestations of their hands. So they'll have pale hands, but sometimes it becomes very red because then you have vasodilation. So here you have vasodilation and vasoconstriction. The ability for the body to mediate this becomes altered. So even with a small stimulus, like, we walk outside and our hands just become white. It's an over-exaggerated response. And then, like, if you get warm, you become very flushed. So it's an exaggerated vasoconstriction and an exaggerated vasodilation. Okay? So the body has a problem mediating this. It can be painful. It can cause lots of tingling, numbness. And like I said, it is often related to systemic autoimmune disorders like lupus and stuff like that. So right? Use the patient. We can teach them lifestyle modifications like avoiding extreme temperatures, things like that, if possible. Smoking cessation, again, is a big risk factor here, especially with the vasoconstriction. But we can use things like calcium channel blockers, which help with a little bit of vasodilation. We can use topical nitroglycerin, which can cause a little vasodilation. And SSRIs, I don't know why they work. I don't know why they use them. They probably either prescribe or don't know either. Sometimes things just are trial and error. Let's work for this too, It's an unexpected effect. But anyway, SSRIs can help too. Probably has to do with the way the serotonin causes changes in the vasculature.
Do you use this for migraines as well?
They do.
SSRIs.
Because there's a theory, because we don't know what causes migraines either. There's a theory that it's an alteration in serotonin. Yep. Which plays a role in vasoconstriction, vasodilation, and other areas is vasodilation that causes migraines. So, what else do I need to say about that? Diet. So, high in natural oils like omega-3 fatty acids. And what do these things do? They lubricate the vessels. They help the blood flow better through these constricted capillaries, small vessels. So think about the fatty acids lubricating. If you take fish oil or great cholesterol, that's why you take it. To lubricate your vessels so that you don't have a lower risk of pericarditis with it attaching to the vessel wall because it's kind of slip on. Don't attach. So a lot of people will call Raynaud's disease red, white, and blue syndrome. You see the red, the white, and down here you can actually see the blue veins if this picture were a little bit better. So you see how there's marked pallor of these digits. You see? Did this happen to you?
Yeah. If I walk out in the cold, it's going to be, my whole hands are going to be white.
You still have a problem with it?
Yeah.
The nurse that I work with has this, and it causes her problems because think about your hands being freezing cold and vasoconstricted and numb when you're trying to put in an IV.
Yeah.
Right? You can't do much. You don't have very good dexterity when you have this vasoconstricted period. All right, more boring stuff. Maybe you think it's exciting. Mitral stenosis, I talked about it a little bit. The mitral stenosis is just what it means. It's stenosis of the mitral valve. Stenosis means what? Closing up, narrowing. Right? So remember where the mitral valve is. It's between the left atrium and the left ventricle. That's the most important side of the heart, right? So therefore, if this valve is stenosed, the blood cannot properly flow from the left atrium to the left ventricle. Therefore, you have decreased end-diastolic volume, decreased amount of blood that is able to be ejected on systole. So you will have signs of decreased cardiac output. But also, you will have signs of congestive heart failure because that blood's got to go somewhere. If it's not getting into the left atrium, it's going to do what? Back up. So it's going to cause signs of congestive heart failure. So remember, mitral stenosis is a big risk factor for congestive heart failure because this will cause cause dilation of the atrium, the left atrium. You have alteration in that part of the heart, which can lead the patient to having AFib. And there's a supraventricular tachycardia. So we're going to talk about mitral regurgitation too, but note the difference in the assessment of the murmurs. So with mitral stenosis, remember that you have a crescendo, decrescendo murmur. It will be best heard over the apex. Why would you listen over the apex? Well, number one, where is the apex? Midclavicular line, left midclavicular line, fifth intercostal space. It's usually on a man about where the nipple is. Okay. So, why would you listen to that space? That's also called the mitral space, right? So that's where you listen. Listen to the mitral space to hear mitral murmurs. Make sense? Crescendo, decrescendo. If you were to hear it, what would it sound like? You get loud and then quiet. Crescendo. Anybody take music appreciation? That's the only reason why you take it for this lecture, right? Because crescendo means what? For the music to get louder, and decrescendo means for the music to get softer and quieter. All right. So loud to soft. All right. So just underline star, right? Have a loud as one, and the dyspnea comes from what? The backing up of the volume into the vascular space, maybe you have a little pulmonary edema. Why atrial enlargement? Backing up into the atrium, right? Stretching out. We've talked a few times about how the echocardiogram can help us visualize the heart and the valves. Rheumatic heart disease and infective endocarditis can lead to mitral stenosis-like problems. We can replace this valve. Low sodium diet. Okay? And treat any signs of heart failure. That's what those medications will do. Decrease cardiac output, right? I hate reading slides to you. Any questions about this? I feel like if we know the patho and the manifestations of the disease, your nursing care should really flow. But I do talk about a lot of nursing applications. Obviously, this is nursing school, but I'm not going to read a bunch of nursing diagnoses to you. All right. Mitral stenosis is the closing or the stenosing of the mitral valve. Mitral regurgitation is what? Where it isn't closed properly and it allows it to back up. Regurgitation means to come back from where it came from. If you regurgitate, you vomit, so food comes from where it came from the stomach. Right? So regurgitation. Let's see. Again, rheumatic heart disease is a risk factor here. Mitral valve prolapse, which is actually common in most women. So probably at least half the women in this room have mitral valve prolapse. It's just very common, but especially if you've had a child. But anyway, it can lead to mitral regurgitation, which actually causes symptoms. All right. So it allows the blood to backflow into the left atrium on systole. So when systole happens, what happens to the tricuspid and the mitral valves? They slam shut, right? So, and then the aortic and the pulmonary valves open. So the mitral valve doesn't slam shut like it's supposed to, and the door doesn't close. It slams shut, but then kind of opens back up and lets it flow back up into the left atrium. Regurgitates back because it's weak, something's happened. It's not slamming shut, it's staying shut on the system. So therefore we have backing up of blood, right? Increased pressure that congest. And we have, again, we can have signs of heart failure. The person can have acute mitral regurgitation, maybe immediately following an MI. I talked about how if the part of the muscle that is infarcted involves that valve and the fibers that attach to the valve and make it work properly, you can have an acute mitral regurgitation because that part of the heart is ischemic and it's not working right. That person is going to have acute symptoms. But the person who has mitral valve prolapse that slowly evolves into mitral valve regurgitation, they're not going to have lots of symptoms. They compensate very well. So the heart gets used to this situation. But they still eventually will have signs and symptoms when it's chronic. There's for your manifestations, the differences between acute and chronic. Similar, DOE is dyspnea on exertion. These are signs of heart failure, right? The acute. As are the chronic, but the chronic signs are not as severe. And so notice the difference in the mitral valve stenosis and mitral valve regurgitation sounds of the murmur. So it's going to be holosystolic. So you hear it throughout systole, and it's going to be about the same volume the entire time. It's not going to get loud and soft. So just remember, holosystolic. Heard during the entire, all of systole. Again, best heard over the apex because that's the mitral space. Remember, in mitral stenosis, you'll have, where to go? Loud S1, mitral valve regurgitation, quiet S1. Look at the heart with these tests. I mentioned how an EMI can lead to this. We talked about how those heart infections can lead to this. And then treatment for the heart attack or treatment for the signs of heart failure. We get them a new mitral valve too. There are a few nursing diagnoses and nothing. Decreased cardiac output, we know why. We don't have enough end-diastolic volume to preload. Volume to be pushed out. What else? So prevention is a big key in preventing mitral regurgitation. How many slides do we have? Not pages, slides. You have 38 slides?
No.
Am I saying 6? Am I saying 21? 20.
Yeah, 25.
All right. We're not going to finish today. But we will keep talking. You want to take a quick break to stretch or take a deep breath or something? Yeah. Stand up and move around. Get your blood flowing. Don't leave. Where's the stopper?
Decreased cardiac output related to and then the whole air.
No, you have no idea.
Let's talk about aneurysms. I'll introduce you to aneurysms, but there's one main aneurysm that we need to talk about for this class. But we'll just go through a few definitions of aneurysms. But an aneurysm is some types of aneurysms are like an outpouching of the vessel wall, the entire vessel wall. So you can think of it that way. If you take a plastic bag, like a grocery bag, you stick your finger in it and it pokes out. That's an aneurysm of your plastic bag. Okay, it's an outpouched, weakened area. Okay. There's two types of aneurysms that we kind of talk about, and a saccular aneurysm is the type of aneurysm where it's truly outpouched. There's an area that has been poked out, kind of. An area is weak. There's also a dissecting aneurysm, to where it's not that it's stretched out in that area or outpouched. It's that you have a tear in one or more of the layers of the artery wall, and there is fluid, blood, leaking into that interstitial space, or inner arterial space. So you have those 3 layers of the vessel of the artery, and there's blood leaking inside of the artery, not bleeding out into the abdomen or anything, but it's bleeding into the artery itself. I don't know if I included this, but you have what the 3 layers of the artery. 3 layers of the arteries are the tunica interna, tunica media, and tunica externa, right? The 3 main layers of an artery. So if the tunica interna becomes torn or damaged, it can leak between the tunica interna and the tunica media, right? Does that make sense? It can leak out. So it's technically an extravascular space because that blood is leaking into a space that is not circulating in the vasculature. So that would be a dissecting type. So here you go. See how it's torn here? It's dissecting type, and it's leaking into one of the layers of the artery. The dissecting is kind of like a false aneurysm. See, dissecting is false, but those true aneurysms are the ones where it pokes out, right? So weakened area. So I said the word wrong, but I had a good guess. But you get the point, right? So what we need to talk about mostly is a type of dissecting aneurysm. And this is a big problem. It's a serious problem. Not extremely common, but it's a abdominal aortic aneurysm. And you'll hear this abbreviated, we'll call it AAA. And what this means is that there's an aneurysm in the abdominal aorta. It can happen at different points in the abdominal aorta, but the place that you would really not want it to happen is right at the renal arteries. But often it does happen right at the renal arteries because it can cause decreased perfusion in the kidneys, which is a bigger problem, right? So when I think about a AAA, I think about a person with chronic hypertension. I think about an old man, and usually they're very tall. Not always. You might know a short white woman, that has, a AAA. But, usually it's older, and I think that African Americans are affected more. That's why I said a short white woman. But because, African Americans are more affected by hypertension, right? So old, tall men with arteriosclerosis. And I think this might happen because the aorta is just bigger. I think maybe it's just kind of stretched out more. But it's just, I don't know the scientific. But I just know that happens. So somehow the elastic component of the abdominal aorta is reduced because of what? Arteriosclerosis. And that artery has been taken, it's the major artery in the body, and it has very high pressure in it. And it's been taking a beating for a long time because of that hypertension. So just remember that when you have hypertension, your arteries really take a beating. So because of all the pressure. So lots of trauma to that abdominal aorta because of these chronic diseases. So it becomes thin. It becomes because of their arteriosclerosis. It ends up eventually becoming thin and weak. The actual vessel wall, the artery wall. And because of the increased, along with the increased pressure from the hypertension, it's going to increase the risk of that artery becoming dissected, torn. So, a lot of times people will be walking around normal every day with a small abdominal aortic aneurysm. The body's compensating well. We're not getting a lot of leakage of the blood into the in between those aortic or in between those vessel spaces. But the major sign of an abdominal of a AAA is a pulsating mass in the abdomen, usually just above the umbilicus, which is what the belly button, right? And you would likely hear a bruit. So remember, you hear a bruit, right? You feel a thrill. We talk about thrills when we talk about renal and stuff like that with the shunts. But you can remember, you listen for a bruit, but you feel for a thrill. Right? So, learn that from Dr. Smith, who taught me AT. Anybody else took him? Any good? Yep. Yes. So, one thing that you would not want to do if you suspect the patient has a AAA, you see a mass or you lightly palpate and you feel it, oh Lord, you listen, you hear a bruit. What you would not want to do then is what? Go mashing on it. Because a lot of times we want to start mashing on masses and see what it is. But if you think it might be a AAA, there's all these signs, don't go mashing on this person's belly. Okay? So the signs of the actual dissection are it's very painful. This person is going to have a tearing, sharp, stabbing pain in the lower back. It might just be back pain, not abdominal pain, but somewhere in this area they will have some sharp pain. Why would they be hypotensive at the point that dissection is happening? We're losing blood volume in between the vessel wall, in between those layers. You would have decreased lower extremity pulses, number one, because you're hypotensive and maybe some decreased cardiac output. But why else may you have decreased pulses in the lower extremity? Blocked. So just think of it that you have blood that is flowing into the layers of that vessel, and what's going to happen? It's just going to begin to grow. It's going to get bigger and bigger, that area. And as that gets bigger, it's going to occlude the actual lumen of the aorta. So you're going to have decreased flow through it, decreased peripheral pulses. Does that make sense? Just going to close off the lumen. This person could advance to hypovolemic shock because they are losing so much blood volume. You could die from this. You may hear the terms dissection and rupture with this. Rupture occurs when the aorta has ruptured. This person is what? Dead. Okay? This person cannot be saved. All right? So if you have a AAA that is dissected and then ruptures, you can't get in there fast enough to repair it. It's like a water hose. It's just think about the amount of volume that is being pumped through the aorta, 4 to 8 liters per minute, right? So, in a normal person, so that's a lot of volume. So if this abdominal aorta ruptures, this person is likely dead, right? So, dissection, rupture, different. But dissection can lead to rupture. We want to prevent that. An abdominal ultrasound is a good choice to look at this. So they will look at it under ultrasound, and they can actually tell the size of the aneurysm. CTs, echoes, things like that can also give us a good idea of what's going on. We want to treat the blood pressure. So the main thing that we want to treat in the AAA is the patient's blood pressure, especially if they're hypertensive. So likely they will be hypertensive. They've been chronically hypertensive. They've been uncontrolled. So we've got to get their blood pressure down if it's not already low. If it's already low, then we probably have advanced a great deal. But the patient probably will be hypertensive, so we want to keep this patient's blood pressure under control, because what is a big risk factor for this? Hypertension, right? So if we have less pressure in that abdominal aorta, we can decrease the amount of tearing or dissecting, so we need to keep the blood pressure down. Often hydralazine or vasodilators are not used because they act directly on the vessel wall, so it can actually exacerbate the function. Not always used. Closely watched. Now I'm going to start using more advanced terms. Hemodynamic parameters, right? We'll start with blood pressure, heart rate, cardiac output. All those things are hemodynamic parameters. CVP, hemodynamic parameters. Often, if the aneurysm is no larger than 6 centimeters, if the patient is fairly asymptomatic, they will continue to monitor this patient. Maybe it will resolve, maybe it will heal. But if the aneurysm or the dissection is more than 6 centimeters in length on that aorta, that is indication for surgery to repair it. And they'll go in and put they'll try to repair it and then put a big mesh stent in there to try to hold everything together. We talked about ineffective ineffective tissue perfusion. And you know why? Because you maybe decreased cardiac output because of decreased volume. You would have decreased flow of blood to the lower extremities, right? Risk for injury, well, that could be meaning death, right? This person will have lots of pain. And then if you told me that my aorta was tearing, I would be very scared, right? So, especially a healthcare professional, because you kind of understand the implication. So, yeah, I think I need that. So pain or anxiety and fear is a big deal. So prevention is a big thing. So hypertension, treat that. Treat the blood pressure, or treat the cholesterol. Diabetes is a big risk factor for this too, because the diabetes decreases the not tone, but integrity of vessels. So that elevated blood sugar decreases the integrity of our blood vessels. That's why a person with hypertension is at diabetes is at increased risk for stroke. All right. What else? Just a list here. Okay, right here. Avoid the Valsalva maneuver. So remember, if the patient has SVT, we can tell them to do the Valsalva maneuver. Take a deep breath, bear down like having a bowel movement. Well, we would not tell this patient to do that ever. So they would have to be on stool softeners. Don't bear down when you're going to the bathroom because you're increasing your abdominal pressure and can cause more dissection or, God forbid, a rupture, right? So tell them not to bear down. We're going to give them stool softeners and things like that to help prevent that. Your assessment is big on the distal pulses to check for the perfusion. Pain is a big deal. So also just remember that when we're in pain, what's elevated? Our blood pressure often. So if we can control the pain, we can often help control the blood pressure. So if your patient has a pain level of 8, 9, 10, and their pressure is 200, don't go get the metoprolol, right? Go get the Dilaudid, right? And it's all over. So here's a nice picture, right? It often happens right around the renal arteries, which are right here. See, this kind of looks like a person, doesn't it? It's a big belly. So this person is nice and lean, so that's a good aorta. This person has a big giant belly, so it's not good. So especially if this aneurysm happens proximal to, above, right, the renal arteries, it can cause a big problem because you're going to cause hyperperfusion to the kidneys. That's bad too, right? There you go. I might be able to power through this. I don't know. Let's see. Shock states. Let's talk about hypovolemic, cardiogenic, and septic shock. In peds, you talked about anaphylactic shock with allergic reactions, I think. And we'll talk about neurogenic shock briefly in neuro. So let's talk about hypovolemic, septic, and cardiogenic shock. You probably thought about shock previously, and you would think shock is what? Low blood pressure, right? Well, yeah, that's number one manifestation of a shock state. But shock really means that we have not enough output, blood flow, and oxygenation to meet the demands of the body. That's technically the definition of shock. So we go into shock when our body can't maintain enough oxygen and perfusion for normal cellular function. So let's talk about hypovolemic shock. Hypovolemic shock is because you have low volume, marked decrease in volume in the vasculature. So what can cause it? Bleeding, right? So what would be the cause of hypotension related to a AAA? Hypovolemic shock, right? So that's because you're losing blood volume. Burns, you're losing either blood or you're losing lots of fluid because the skin is gone, which allows fluid to just seep out and evaporate everywhere. Even severe gastroenteritis, nausea, vomiting can lead to this. All right? Third spacing, remember that's where fluid goes into somewhere other than the vascular space. Third spaces, the tissue somewhere. So you're losing intravascular volume because of that. So, I've made this look really complicated, but it's not. So for some reason we have blood volume loss or intravascular volume loss, because not necessarily is it blood volume loss, it might just be fluid volume loss. So initially, you will have decreased volume, you'll have decreased cardiac output and blood pressure, mean arterial pressure, right? So therefore, the body will try to compensate. How does the body try to compensate? Increasing the heart rate and increasing the stroke volume. The stroke volume is how hard the heart's squeezing. So the heart's going to start squeezing real hard and real fast to try to compensate, and it will compensate. Also, the way that our body compensates is by causing vasoconstriction. Right? So our adrenal glands will release some epinephrine, and that does all of these things: vasoconstriction, increased contractility, increased heart rate. And that peripheral vasoconstriction causes increased systemic vascular resistance. Does that make sense? Why?
Yeah.
So if you have constriction of the systemic vasculature, you're going to have increased resistance against it. Kind of like afterward. That will increase the blood pressure. If the blood has to go through a smaller space, it's going to go through much faster and perfuse better. It's like if you have a water hose and it's on sparely, it's trickling out. If you squeeze it, it's going to shoot out, right? That's what happens. But if the blood loss or fluid loss is not corrected, the body will continue to compensate, more vasoconstriction, and then a more elevated heart rate. But the heart rate can only increase so much to compensate, because eventually when the heart rate gets so high, maybe around 150, 170, it becomes so fast that you can't, there's no time for what? Filling it. So it's just pumping, there's no time to get anything in it in order to get out. So as this volume problem is not corrected and the volume continues to lose, then the blood pressure and cardiac output will begin to fall. That's when we say that the patient is decompensating. We're compensating by doing all these mechanisms that we want to happen, but they can only happen for so long. Then eventually the body will decompensate. The cardiac output and the MAP falls, and therefore we're not getting proper amount of perfusion, nutrition, oxygen to the cells, and therefore our body goes from an aerobic metabolism state to an anaerobic metabolism state, which is not good. All right. So, and then these things can happen: cell death, organ failure, and eventually the patient can die. All right. So, let's see. Let's go through these manifestations. There's a lot of them, but I think that you can figure most of them out, why these manifestations happen with hypovolemic shock. Lots of them come about because of the signs of decreased cardiac output. Lots of them come about because of the signs of decreased volume. So, cold, pale, moist extremities. What's happening here? Vasoconstricted, right? The skin is low priority when our brain is not getting perfused. Well, you'll be thirsty because you're hypovolemic. You know that you get thirsty even when you lose about only 1 to 2% of your blood volume. So your normal blood volume, and you've lost 1 to 2% of that, that's when you get thirsty. Even that small amount. So our thirst center is very sensitive. Initially, you'll have a slightly decreased urinary output. If you notice that these manifestations go from initial to later, I put them kind of in order as they will show. Does it make sense? They get worse and worse. So the patient then will become hypotensive and tachycardic. Mental status changes because we have decreased perfusion of oxygen to the brain. All right. Urinary output, right, continues to fall. Urinary output is a very good indicator of cardiac output. What else? Mottled skin is also a sign of vasoconstriction and hypoperfusion to the skin. Do you know what mottled skin looks like? A lot of you have probably had mottled skin. If you get cold, it gets kind of blotchy. It's just hypoperfused skin. And anuria, the patient eventually will have no urinary output and decreased and diminished pulses or absent pulses. So we have to figure out what caused this state of hypovolemic shock. The person will have an elevated lactic acid. Why? We're in anaerobic metabolism. Exactly. Breakdown of muscle and things like that for energy. You release this lactic acid. The ABGs might show that the patient is acidotic because of the lactic acidosis. Right? CBC can tell us about the hemoglobin and hematocrit. If it's low, the patient's bleeding, things like that. The patient has an infection, and maybe that's the problem, but that's more septic shock. CMP tells us about the electrolytes, right? CVP, fluid volume status, and diastolic volume also tells us about fluid volume status, how much volume is there when the heart is pumped out. And you're thinking, where in the heck are you getting this EDV from? Well, it comes from a machine, and I'll just show you in a minute. Okay. The patient that is hypovolemic, what do you think we need to do to treat them? Replace the volume, right? This person the volume has to be replaced somehow. So think of this, I put it in quotes, underline it, put a star by it. Fill the tank before you start the engine. So you fill the tank by giving the patient blood and fluids. Okay, we're filling the tank. Hopefully that can correct the problem. Crystalloids, colloids, and blood products. Usually we will use like normal saline or something like that first, lactated ringers. Why would we use those first? They're isotonic, and they help to expand intravascular volume. Yeah. There's another thing that we call Hespan, and some use it, some don't, but it's a type of fluid that really helps to expand fluid volume. We may need to support the blood pressure if we don't have a response to the replacement of the fluid volume. So if the patient has given 10 liters of fluid, maybe that happens, and the patient's blood pressure is still low, they're bleeding out, we can't get the blood pressure up, we can give them medications, and we've talked about these a little bit, the inotropes, the vasopressors, the medications like Levophed, dopamine, and things like that we can give to increase the patient's blood pressure. And we'll talk even more about those meds probably on Tuesday. But remember that we want to give fluid before we give vasopressors. So fill the tank with fluid before you start the engine with an inotrope vasopressor. Okay? So we start the engine with the vasopressors. This patient is in severe acidosis. We can give sodium bicarbonate. It's a quick fix. Often when the patient is in a severe acidotic state and we give them medications like Levophed to increase their blood pressure, it doesn't work very well because those vasopressors don't attach to the receptor sites in an acidic environment. So often when we push bicarb, we'll have an initial increase in blood pressure, but it's very temporary. The patient's going to get acidotic. So sometimes I'll give them a drip of bicarb, but not very often. Hypovolemic shock, right? Septic shock is very similar to hypovolemic shock. It's caused by a different reason, but let's talk about it. So this patient has sepsis, which means what? Infection in the bloodstream, right? This patient has a bloodstream infection. So, and the shock happens because of the effects of that. This is a big problem in patients who are in the ICU getting septic shock. So because look at these things, bladder or catheters, IV access, airway, artificial airways. These are big risk factors to get a bloodstream infection, which can lead to septic shock. I enjoy this path though. So what happens here is that the patient has a bloodstream infection. SIRS is a systemic inflammatory response syndrome, right? So that kicks in, which isn't always good. But the inflammatory response system happens. The white blood cells kick in, and they go to work. The white blood cells go into the bloodstream, and they migrate into the bloodstream and from the bone marrow and whatnot, and they attack the bacteria that is causing the sepsis. While they're doing their job, the white blood cells, they go in and they attack the bacteria, and they kill lots of the bacteria. But what happens when bacteria is killed within the bloodstream? The bacteria releases enzymes when they die. So they release things like cytokines. They're things that are released. What these cytokines, endotoxins, what they do to the blood vessels is not good. So they damage the lining of the blood vessels. They decrease the ability of the blood vessels to constrict like they're supposed to, and those endotoxins increase the ability for volume to leak extravascularly. So it makes the vessels permeable. Those endotoxins make the blood vessels more permeable. So what happens? Intravascular volume is shifted extravascularly. The patient is not vasoconstricting very well, so they can't compensate very well. What else? It also causes changes in the coagulation factors, and the ability to clot is decreased. So this patient is increased risk for bleeding, which causes what? Hypovolemia. Initially it's hypercoagulable, but that will diminish the clotting factor, so the patient then is at increased risk for bleeding. Vasodilation, right, because the inability of the vessels to constrict because of those endotoxins, and also those endotoxins have caused the fluid to leak extravascular into the third spaces, and the patient will have signs of shock, hypotension, decreased cardiac output. All right, this is really too much for you, but I said SVO2, and SVO2 is the O2 sat of the return blood. So this tells us how much oxygen the body is using. So, our O2 sat normally would be hopefully about 97 to 100, right? And the blood that's returning to the body usually is about 70%. So we only use about 30% of that total 100% that we have. But initially, that might be increased because the body is not using that oxygen. It's unable to use the oxygen because it's in an anaerobic state. All right? Anyway, it's too much. Yep. Decreased blood pressure, and you will have decreased systemic vascular resistance with this. Why? You have profound vasodilation. The output load is low. So you can initially have increased cardiac output, but eventually, because you have increased cardiac output initially, because you don't have any output load, that heart's just dumping all that blood all out in there because there's no resistance. But eventually that will not happen and the cardiac output will fall because of the profound hypovolemia. Early manifestations, later manifestations. Initially the heart will compensate, or the body will compensate very well. The warm phase. We call it the warm phase because in this period the patient has a fever from the infection. The body's compensating fairly well. They're tachycardic, they're deep, rapid respirations to assist with what? The acidosis. The body will initially flush, vasodilation, right? Warm, flushed skin, fever, and vasodilation. And because the body's compensating, we can still have a normal urinary output. But eventually, as the body decompensates, so you can say body is decompensating, aero. Later phase, so the patient will become hypothermic. So you always haven't thought about infection and hyperthermia, right? Sometimes our patients are infected and they are hypothermic. So these are worse signs. So the patient is warm here, but they get cold here. The skin is cold because it's hypoperfused. Low blood pressure. Weak or absent pulses. All right? Urinary output falls. Got it? So how are we going to diagnose septic shock? We're going to do blood culture. We're going to see what is causing the infection. We're going to look at the CBC. We're going to look at lactic acid. We're going to look at the ABG for the acidotic state, and all of those things. PT, PDT, we have alterations in what? Coagulation here. All right? And all of these hemodynamic parameters. Patient will be on antibiotics, right? We must replace the patient's fluid volume. If by simply replacing the volume is not enough to increase the blood pressure and cardiac output, we can start the engine. We can give them vasopressors to increase the blood pressure if necessary. And those usually work by vasoconstriction and increase cardiac contractility. Some physicians will order corticosteroids, and that decreases the systemic inflammatory response, which is partially causing the problem here. It's not always used, but sometimes they will prescribe things like methylprednisolone and hydrocortisone. Oh, I don't think I can do cardiogenic shock. All right. So those are the two big ones to learn together: septic shock and hypovolemic shock. Because in the end, it's really the same thing, right? The patient is hypovolemic because the fluid has shifted into the third spaces because of the effects of those endotoxins and broken down bacteria and sepsis. Right? Your head's swollen right now. So I'll stop. I have to stop. But so remember this passage, 2 hours. I know we can get through it. But we only have, 1, 2, 3, 4, 5, 6, 7, 8, 9. Yeah, just a few slides left on this. It's okay. 8 slides.